This is the Neurosurgery Podcast. Welcome back to the Neurosurgery Podcast. Today we are joined again by an old friend who we love having on. I'm going to say it every time, the media mogul of medicine. That's right, Scott Becker of Becker's Healthcare and the entire media Becker's ecosystem. Scott, you've been on the show, I think, twice before. This is your third episode on with us. Welcome. Please take a moment to say hello to the audience.
Well, thank you so much, Dr. Wing, Dr. Cocoon. It's always a pleasure to visit with you folks. Just excited to visit. I know we've got an interesting topic today, and always a pleasure, and love getting a chance to talk to orthopedic and spine physicians. Nothing better. So, neurosurgeons, thank you so much.
So let's dive right in. As you alluded to, you were on about a year ago where we gave Becker's top 5 trends to watch in 2025. And now that 2025 is in the rearview mirror, I thought we could revisit that list and just see how those things panned out in terms of not overt predictions for this or that, but just what are areas of interest, areas of activity, things to keep an eye on. And as we go down this list, I'd say, in addition to the media mogul, you could do a part time as Nostradamus. You really did have your finger on the pulse of the healthcare industry in our country because, as we'll see, big moves happen in a lot of these areas. So we'll begin at the beginning. The first area that you said to watch last year was the healthcare physician workforce, and in particular, shortages that we were facing. So where do we stand now, Scott?
Sure, sure. I mean, one of the challenges with, and JP, Michael, thank you so much for having me. One of the challenges of our healthcare system is you and I talked for a moment a few minutes ago about the predictions I made last year, the things to watch last year. It's not so much that I'm Nostradamus, because I'm not. So many of the things are so clear. They're so clear. And we see them so clearly, as do most of us. And one of the great challenges is we see them all clearly, but they don't necessarily hit the political radar in the right spot, or in a spot that people really want to deal with these challenges. So when you talk about physician shortages, we all know that physician shortages are daunting. And I divide this into two different ways. I divide it between primary care and specialties. And what I say about primary care is not liked by a lot of people. It's not what I prefer, but the reality is, on primary care, the projections are, the concepts are that we're 200,000 short of primary care doctors. We produce about 10,000 primary care doctors a year, about. We produce in total about 25,000 doctors a year. When you look at primary care, we all see it ourselves. When I went to reschedule my primary care physician appointment last June, the next date that he had available was April of 2026. And again, I have access. The primary care doctor is a close friend. I was able to move that to get it into November. But I live in the healthcare sector. I'm not a physician like you folks are, but I'm very connected. But think about that. For me, off the rack appointment with my primary care doctor I've seen for 30 years, who I love, a close friend, close colleague. I've known him since I was a kid. The next available appointment was literally about a year out. And so with access, I'm able to get in earlier. I was able to get in several months earlier, work it out, convenient to him, convenient to me. But that's a disaster. And what it points to me is the game of having a physician as your core primary care physician, is a luxury that we're not likely to have in the next generation. So we're so far behind what we need in terms of primary care doctors, that one way or another, in terms of primary care, we're moving towards PAs, nurse practitioners, with some oversight by primary care physicians. It's not that I'm saying this is what I want. This is where we're at, and this is where it's likely to go. Uh, I think either both you or one of you spends a lot of time in Florida. Florida's a great example of a state where if you want a new primary care doctor, you almost have to hire a concierge. You almost have to get concierge doctors. And I know that's one of the points we talked about as well. But that's an evolving issue throughout the entire country. It's not just Florida. Florida was one of the earlier places where it just got lots of people, not enough primary care doctors, so you move towards concierge. So what does this mean in terms of specialties? The, 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 where this problem is even worse, When you get to specialists, now, what I said about primary care, again, it's not the preferred answer. It's not something primary care physicians like to hear. Whenever I say this, the guy who runs the American Academy of Family Physicians, who I think is a fantastic person, Dr. Marshall or Sean Marshall, doesn't like it. But my perspective is we've lost that war. We've lost that game. So we better figure out a way for MPs, nurse practitioners, PAs, and others to provide the majority of primary care service going forward. In specialties, this is much harder because it's very hard to have a PA or nurse practitioner do brain surgery. It's not really doable. It's very hard to do a lot of things that specialists do to have them done by PAs and NPs. I just don't see it in a lot of areas. Oncology is a fascinating situation. Oncologists in our country are burnt out, they're overwhelmed, they're information overloaded, and I don't see a good answer around it. When you look at the like specialty cancers, rare forms of cancer, and you look at even regular cancers, not that there's such thing as a regular cancer. A regular cancer is a cancer that somebody else has, of course. But when you look at cancer, and we're of the age, particularly Dr. Wang and I are, we have plenty of friends, colleagues, family members that have died of cancer, and all of us do. Everybody's touched by cancer. What you find is the depth of specialists in cancer and oncology is very narrow. Once you get past the starting point, or you get past a few of the great institutions in our country, the Mayos, the Cleveland Clinics, and so forth, the depth of oncology providers of true oncologists that are really deep in specialty areas is very small. And so what does this mean? That means that for residency spots, for things going forward, we have a hard choice to make as a country that nobody wants to make. Do we want to double and triple down on residencies for specialists because they're harder to substitute than our primary care physicians, for example? And I'm not advocating that we don't love our primary care physicians. I'm just saying that the battle of producing enough primary care physicians is largely lost for the next 10, 20, 30 years unless we do a dramatic change. We haven't yet lost that in specialties, but we're very close. We get a chance. One of the beauties of what I do for a living is I talk to physicians and health system leaders every single day, all day. So I had on a dermatologist not that long ago who's in Minnesota, in the part of Minnesota that she's in, lots of Scandinavians, one dermatologist for 500,000 people, lots of skin cancer, just numbers that don't work. A neurologist in Texas, the whole country, it, as we age, has more and more dementia, Alzheimer's, brain illnesses, or challenges of aging and all kinds of challenges. I probably describe it the wrong way. You folks are specialists and physicians, probably don't call it brain illness, but we've got all kinds of challenges of the brain that neurologists, are the key person to help diagnose. One neurologist for 700,000 people. The numbers are just out of whack. We know it because whenever we have a family member or a friend or a colleague with a form of cancer or a challenging disease, we have to call in favors to get that person to the right person. And
Yeah.
that's and again, when you want to talk about health equity, that's a disaster because you folks have the ability to do that. The people that listen to this podcast might have the ability to do that. But even all of us that are somewhat connected, that's getting more challenging because everybody that has those connections finds all those connections are overwhelmed as well. So
Right.
so so in terms of specialists, in terms of physicians, I think it's getting worse and worse. Government doesn't like to talk about it because it's so easy to talk about other stuff versus solving problems. You talk about the subsidies under the ACA, you talk about the insurance, you talk about all kinds of stuff. But the hard problems that aren't even that hard, producing 7,000 more residency spots, we all know there's enough medical school spots, but the medical schools can't let enough people in because there's no place to put those people into residency programs. And getting into residency programs is brutal. There's just not enough residency spots. But it's not that it's easy to fix, but it's solvable, and we need to solve it.
So Scott, for our listenership, that is very positive because right now people are worried about getting a job. But would have put a pin in that. I love that. That's a very positive note for people listening to this podcast because it means there's a bright future for us. There's a need for us, right? But going along what you just led into. What about the issue and your predictions about the insurance and payer industry? I mean, this is something that is really front of mind for most people in practice now, right?
Sure. Yeah, I mean, the insurance industry, one of the challenges of our healthcare system is it runs on massive government monies. 50% or so of now of healthcare is paid for by the government through Medicare, Medicaid, and other ways. Um, and, and and that's bad or good, and it's not changing anytime soon. It's just not changing anytime soon. The challenge with it is when monies flow through from the government to the insurance companies to the health systems to everybody else, you've developed a complete system that's built around what we used to call in business other people's money. So when
Yeah.
you talk about other people's money, the
Great movie.
best, yes, other people's money. It's a movie, but it's also a concept.
Yeah.
The best customer for anybody is someone who's paying with other people's money. So the best customer for a hospital is a patient because the patient's not paying with their own money, and the best customer for a higher education institution today is a student who's taking out a ton of loans because that student's not paying with, they don't think they're paying with their money. And what this has led to is massive inflation that runs through the system, and it's almost uncontrollable and it's almost unchangeable because the reality is no government, they talk about in this administration trying to reduce some of the money that flows through government healthcare, but they're talking about money at the edges. I mean, they're not talking about. I mean, I know that the health system world and the physician world gets really upset about it. So much of it comes out of their pocket, but in reality, the total dollars they're talking about changing are so small compared to our GDP and compared to what's spent on healthcare because they can't change it. On one hand, we know we have a crazily inflated system. On the other hand, there are a lot of poor people and people that don't have great incomes that rely on those government subsidies that flow through the system to pay for healthcare. So you're every government, Republican, Democrats in a total box. They don't really want to deal with it because the people, healthcare costs for a family of four now are 30 to 40,000 a year. 30, it's 27,000 or so for insurance, those 6, 7,000 for deductibles. A huge percentage of our population makes less than 80 to 100,000 a year. I mean, the numbers just don't work. So it's nobody really wants to take away subsidies totally, whether you're a Republican or Democrat. At least the politicians don't. And at the same time, we know that all those subsidies have crazily inflated the healthcare economy over the last decade or so. The losers in it, of course, the inflation where the escalation is not going up is for physicians because they have they're the populists in government hate the physicians because they think they make too much money and because the lobbying for the physicians has been so splintered that it's no longer as powerful as it once was. You
Yeah.
follow me? So you sort of like the CMS people hate anybody that makes more than 300,000 a year, and the fact is, we've got a supply and demand problem. We don't have enough physicians. We need a lot more of them. Even specialties that we thought there were more than enough of, like so many specialties people thought were going to be replaced by preventive medicine, by AI, by other things. Gastroenterology is a great example. We're back to again a shortage of gastroenterologists. You want to get even your colon screening done. You've got to wait in line for it. It's a while. I mean, some areas aren't as short as others, but GI has become one of those areas. You've got more and more areas where the quality's not deep, or there's just not enough doctors, and it's going to get worse.
Yeah, well, Scott, I love your discussion about other people's money. We've had a few episodes lately and some conversations about this dissociation where the patient is the consumer of healthcare, but they're not the customer. And it's exactly as you described. There's a movement going on right now called Fund the Patient that the CSNS is a part of. We've talked about it on this show with Anthony DiGiorgio and Lou Toomey Allen. We've actually got an editorial coming out in the JNS probably this month, if not next month, about that. So we'll link to all that for our listeners. Really important topic, but kind of tied in with this discussion about where the money's actually coming from. The next trend you spotlighted for us to watch was Medicare Advantage. And I wonder if I could put a little twist on this. And instead of just specifically discussing the Medicare Advantage plans, once again last year, it's reared its ugly head as this discussion of Medicare for all and trying to move towards a single payer system, which I thought, how could we not discuss that so apropos when you're talking about shortages and waiting months and years for a colonoscopy, which is, of course, the end stage of single payer systems, is shortages and long waits. So maybe we could put a twist on this next prediction and talk a bit about the new calls and the new trends of people once again seeking single payer and Medicare for all in this country.
Yeah. So what happens is you've got a few different disconnects and challenges. One is most of us in healthcare would like to have everybody have coverage. And that's why this concept of Medicare for all or some kind of coverage for all is a popular concept. The problem that we have is when we talk about Medicare for all, when we talked about the ACA, you talk about all these things. What you have is people, I mean, it's the oldest thing in the world. People are writing checks that they can't cash. So if you're going to have coverage for all, this is the problem with our politicians and our political system. It's on the right and the left. If you want coverage for all, I'm fine with that. I think we ought to have coverage for all. I think one of the benefits of the Affordable Care Act is we took down to about 89%. We took down to about 8 to 10% of people that aren't covered, like to have people covered for all. But if you take care of one part of the issue, which is the political issue of coverage for all, but not the other part of the problem, which is the supply problem, having enough doctors, nurses, people to take care of people, you have a total disconnect. So you're sort of you're sort of on paper solving one problem, and this goes back to the old adage: coverage and access are two completely different things.
Yeah.
If you get coverage for all, fine. Most of us want everybody to have coverage, whether you're poor, you're white, you're black, whatever you are, we want you to have coverage. Most of us want people to have coverage in the big scheme of things. Now, you could be the hardest core capitalist and say, no, people shouldn't have coverage if they couldn't pay for it. But let's take that out of the equation and say, we'd like to have everybody have coverage, regardless of race, religion, whatever they are. We want everybody to have coverage. But coverage without access is illusory. It's just a name. Medicare Advantage, again, another disaster. It's just another flowing of money from the government through the insurance companies that just inflates the cost of healthcare. Why does single payer become so popular? The idea becomes so popular. It's not because we want socialized medicine. It's because the entire flow through now of dollars that go from the government to the payers has led to, for all practical purposes, just another tax on the entire system. So there's a simplistic mindset without looking at the long-term consequences, Dr. Colquhoun, of this concept of like, if we got rid of all the payers, we would take a tax out of the system. 5 to 7% of costs go through the payers that seem to have just been a tax on top of taxes on top of taxes. Medicare Advantage is the perfect example of a government program. Projected to save the government money has ended up costing the government a lot more money per Medicare beneficiary. So just ultimately just a debacle. And now 54% of people are on Medicare Advantage. Providers, health systems are all trying to back out of Medicare Advantage. It's Medicare was one place. As a physician, as a health system, you knew what you're getting paid. You knew when you were getting paid. It might not be perfect, but you didn't have to mess with all the payers. So what happens is there ends up being a movement, a popularity to the concept of single payer. I agree with you. When we compare ourselves to other countries that have single payer or socialized medicine, exactly what you're talking about. Long waits, horrible care, you don't get what you need. And there are examples where that's different. There are examples of countries with 5 to 10 million people where it might work. But you can't compare us to that.
Yeah.
We have 350 million people. I compare us to China and India, 1.5 billion. We're the third largest country in the world. And China and India, going back to the shortage issue, they do a couple things right, but one of the things they do wrong is not wrong. It's an insurmountable problem in those countries. They've got 1.5 billion people or so, and not nearly enough nurses and doctors. And so these things all tie together. If you want coverage for all, single payer, okay, but we need enough nurses and doctors. Like I'm not adamantly against it or for it, because we've ended up with a disaster with four of the largest insurance companies are four of the top 20 largest companies in the country right now.
Yeah.
United and CVS being 4 and 5 are the largest, actually largest companies in the country, and they're the largest companies in the country because so much government dollars flows through them, both from a state level and a federal level. So I mean, single payer, that's not the problem. coverage versus access is the problem. And it's not that I'm pro single payer. I'm not, but I'm not. That's not the problem. The problem is we don't have nearly enough doctors and nurses to provide coverage for everybody.
Well, Scott, I think of all your predictions, you're most spot on with timing on that because if you look at doctors, health systems or hospitals, and the insurance companies are all backing out Advantage. This new administration that is not new anymore, the Trump administration, is probably going to look for a huge clawback in their litigation against United. And I mean, if all you got to do is open the paper and see what's happening, your prediction was spot on in timing. But along those lines, there's been a lot of recent chatter in the papers in the Wall Street Journal about how AI is using healthcare as its proving ground, and their biggest early profit taking will probably be in the healthcare arena. This is being discussed very, very openly now, right? And the next prediction you had was about tech and AI. So I want to hear how you feel about your reflections on the last year on this.
Sure. What I think about tech and AI is as follows: is that I'm a huge fan of trust but verify. So what happens is, and again, tech is great and we need it in a lot of places. But my belief is you need tech plus physicians and nurses. You need both. You can't, like, you have people online that will say, and JP and I follow each other online, so we see it. People say we don't need doctors anymore because you're going to have AI take care of everything. And I think again, it's almost like the concept in China and India, and this is not a knock on. We are so fortunate in our country that so many of the best physicians from those countries come here to practice. So thank God for China and India. But they tried to move towards preventive medicine by necessity because there's not enough doctors and nurses. If you look at COVID, it was a debacle. China had to close down lots of places because they just didn't have enough nurses and doctors to take care of people. India went through a couple summers of just an absolute disaster because not enough nurses and doctors to take care of the side problems they have. And I don't fault the Chinese government, the Indian government on this point at all. It's just a lot of people to take care of. So technology is a helper. It's very important. It's very important to trying to solve healthcare, but but we can't lose sight of the fact that we better have technology plus doctors. You need both. And I think a lot of the AI stuff, extremely helpful on the administrative side, increasingly helpful on the diagnosis side. I mean, I over Christmas break had to go to the urgent care for something. First, I went on ChatGPT. ChatGPT actually nailed it, but I went to the doctor, the urgent care. Saw a PA who took care of me, and it was exactly what sort of ChatGPT said. And that's for a simple diagnosis.
Yeah.
That's for a simple diagnosis. That doesn't mean for a complex diagnosis inside all the problems, and it also doesn't mean that he need a doctor or PA to actually go through to make sure with the experience that she has or he has to really go through the whole thing. So very helpful, lots of use cases. But this concept of countries that say we're going to rely entirely on prevention, like RFK says I should do more pull-ups, fantastic. But I better have doctors and nurses too, just in case. It's both.
Yeah.
It's really both. I think there's a lot of room for use of AI throughout a lot of our use cases.
Yeah.
Uh,
Well, Scott, next time just text me and I'll ask Grok and then give you an authoritative answer myself. Um,
exactly,
but
exactly. But
But yeah, I do. I love following you on X. Everyone should follow Scott on X. He has fantastic posts about healthcare and quotes of the day, lessons of the day. They're fantastic. But as we reach the end here, we're short on time, and so I want to try to set you up to discuss this last prediction with again a
yes,
little twist on it. It's concierge medicine, but since we talked about it before a little bit as a response to the workforce shortages, I think your point was spot on that it is kind of a natural outgrowth. We talked last week with Dr. Adam Seafu about the medicalization of everyday life, and as more and more parts of what used to be normal life become healthcare and medicine, that adds to the burden of our already too small workforce because people are coming to the doctor too much. Add to that all this coverage and all this quote unquote free preventative care people are going to the doctors more and more and
the
more.
and I thought, Dr.
Yeah,
Cocoon, I thought I was right on concierge medicine, and then Dr. Wayne said that my best prediction was about Medicare Advantage, so I take
right.
umbrage to that. No, I
Well,
say
here,
that jokingly.
no, but here's the question I want to ask you about concierge medicine because at least the majority of cases I've seen where doctors move in that direction, it's usually primary care. Do you see a venue or some kind of model of concierge type medicine for the specialties,
A
even
hundred
for
percent.
surgical
It's
specialties.
already moving in that direction.
Yeah,
And I'll tell you, in the last 6 months, I heard of a huge dermatology practice that now charges an admin fee. If you want to be a patient of theirs, you pay $250 a year in addition to whatever you pay, and they're a huge practice. And that's
Yeah.
part of just that's like a concierge fee. There's a cardiology practice up north where I live in Chicago that now has gone concierge. So now instead of seeing whatever amount of patients, the person sees patients on their concierge list. And I think, it's just a strictly a rule. I don't blame the physicians on this one bit. Years ago, we saw people in spine surgery, particularly, go cash only, for example, where they're only going to see patients that will pay cash only. It was a way to sort of have a different way of practicing compared to dealing with the insurance companies, the government, and everybody else. I don't blame physicians at all. It's completely a symptom of our supply and demand issues, and so you have more and more of this, and moving in that direction. I saw something pop up saying I use too much hand gestures, so I'll try and stop. But
I'm
it's
Italian. It's okay.
That's great.
exactly. But but no, I think concierge is just, it's a sign of a bigger problem. What you really have in American healthcare is we always had this tiering of healthcare between people that had commercial insurance versus people that had Medicaid or Medicare or didn't have insurance. Now you've got this really huge additional tier where within commercial, you're going to have a percentage of people that have concierge physicians and help and special excellence and quality. You've got a huge amount of commercial people that are scrambling to find coverage. You still have Medicare, Medicaid. They need to be able to scramble to find coverage. And in a place when supply and demand gets out of whack, health equity always gets whacked. You
Mm.
follow me? And it's not like and what happens with the government, like when we talk about coverage for all, on the left they talk about coverage for all. Even on the right, we want coverage for all. Everybody wants coverage for all, but you can't have coverage for all without taking care of the supply problems.
Yeah, Scott, it's very interesting. For the first time, I met a concierge spine surgeon, and I was like, "What is?" You're like, you're getting ready for like a spine surgery, and I didn't even understand it, but someone's doing it already, and I think you're right. I think that people are looking for ways to gain access to the right patients and patients to the doctor, and this may be one of the conduits, but because you were so accurate last year with these 5 predictions, I want you to offer up not a prediction, but maybe more of an announcement. And I don't want to have you tip your hand, but Becker Spine, I think that's where it started, has been amazing. You have taken over everything. You are our conduit of information. I say it all the time. What is Becker's going to be doing in 2026? What are you guys going to be doing that you want to tell the world about that's exciting? Because you always got something new coming.
Yeah, no, no, no. We are a big believer in this concept of working closely to our adjacencies. So we always start with where we do well. I'm a huge believer in whatever you do, know what you do. We spend 80% of our time doubling down on the things that we do. So if our big meetings around orthopedics or spine, around hospitals, health systems, whatever they are, we start there. And then we add things around them. So, for example, in April, we had it a couple of years ago, a Chief Pharmacy Officer Summit, just because there's so much interest in the pharmacy area, not sort of not the Walgreens CVS stuff, but in the pharmacy and as it relates to hospitals, health systems, and physicians, and so forth. Mark Cuban speaking there. And just interesting, these different areas. We've added an oncology summit. There's just so many challenges and problems. A lot of these are attached to our annual meeting, but there's so many challenges and problems around all these areas, and people trying to find solutions. Like, I don't we could talk about this for hours. The shortage issues in specialties, particularly in rare areas, not even that rare anymore. But the inability to find help when you have a loved one that has a real problem, and it's going to get a lot worse.
Well, Scott Becker, you always make our episodes exciting and engaging, and all the listeners out there need to be coming to the Becker's meetings, whether it's hospital or spine or whatnot. Read the emails; they're full of valuable information. Scott, let's make this an annual tradition, right? We got to have you back every year.
Well, we love getting a chance to visit with the both of you. So for me, it's a total pleasure. So anytime, and thank you so much for having me on. Thank you.
Thanks, Scott.